rounds. And we've got an interesting topic, the surgeon factor in cataract and refractive cases, how to make an easy case difficult and vice versa. And I think we can all relate to this very much, so thank you so much. Amy Lynn is in Salt Lake City at the Moran Eye Center and doing cornea, anterior segment, and refractive surgery, and got her undergrad and medical school training and residency training at Northwestern University, and then went to California at UC Irvine for fellowship in cornea and anterior segment and refractive surgery. So I've known Amy since we were in the kind of same cohort going through, and that's when I first met her. And so her interests are very much what my interests are in terms of doing cornea work, anterior segment cases, and then the refractive spin on laser and IOL-based procedures. So, Amy, thank you so much for joining us at the end of this day, and we look forward to what you have to say.
Yeah, well, thanks, Kasha, for inviting me. I'm really honored that you guys are you invited me to give this talk. I just have a few cases of kind of unexpected things that can happen in the OR. I'll kind of explain what my title means, how to make an easy case different and vice versa. I've got no financial disclosures here. So interrupt me at any time if there's an issue with the audio or any video issues. So, we've all heard about the surgeon factor in cataract surgery. So it's a personalized IOL A constant, where you kind of start off with the manufacturer's recommended A constant, and then kind of using your own cases with stable postoperative refractions, you can use that result to kind of tweak the A constant slightly for your own personalized A constant. That's not what we're talking about today. So I'm talking about an alternate surgeon factor. So I'm kind of defining this as a way in which a surgeon produces an unexpected outcome, for better or for worse, and how to get out of a bad situation. And also I've got some cases which are painful for me to watch about how not to get out of a bad situation. So I hope that we can all kind of learn from these experiences. And then there's some cases where things turned out unexpectedly better. So I'm kind of, that's my take on better to be lucky than good. So this is cataract surgery that I did probably about 5 years ago now. And it has so far been quite uneventful. I'm going to be putting in the IOL. And this is just a standard single piece acrylic ZC blue lens going in. And, happy that the case is going to be done in a few minutes. And, the IOL goes in, it's starting to unfold. I tuck it into the bag. Things are great. Get the IA. Gonna take out the viscoelastic. And it's unfolding pretty nicely. But it decides to flip on me, which had never happened to me before. I thought I'd waited long enough for it to unfold. So, I thought, well, it flipped so easily going in, maybe it'll, I can get it to unflip. But, of course, by this time, the optic has actually kind of been folded fully. So it's really tough for me to flip it. So I'm keeping the irrigation in there. I'm thinking I can kind of flip it, but I'm having some trouble. So I'm kind of still, flipped upside down. So I try to, maybe flip it the other way. And, kind of trying to flip it the other way and having some trouble still. But I'm able to finally get it flipped over in a minute. So it's always painful at these moments, kind of watching this, because it seems like an eternity to kind of progress through a case. So I get it flipped over, and it's hard to see on the video, but if you remember with these IOLs, they do have a square edge that's sharp. So I actually caused a gigantic posterior capsule tear. So there's pretty much no posterior capsule support left over. Rexus is still okay. So I'm realizing this and realize that I gotta take this IOL out now, because obviously it can't stay in the eye. So I'm trying to maneuver it so that the eye wall doesn't fall back. And I maneuver it kind of into the anterior chamber as best I can. And I'm going to doing this a bit as carefully as I can. I'm going to just get it into the AC. Okay. So I know I have to do an anterior vitrectomy. So I want to make sure first that the eye wall doesn't fall back. So it seems stable-ish. Get it out. I keep my irrigation in and get some viscoat behind the IOL to push as much vitreous back as I can. So put a whole bunch in there. And again, there's really no posterior capsular support here. And then I took it up and I'm going to put some more viscoelastic kind of on top of the optic because I'm going to be explanting it in a certain way here. So so again, I've got kind of a sandwich of viscoelastic. I've got a bunch behind, I've got a bunch in front. And then this is my technique for explanting an IOL. So I actually make a nasal paracentesis, make it a little bit bigger than normal. And I'm going to enlarge the wound to about 3 millimeters. Then what I do is I take a cyclodialysis spatula and go underneath the optic. And then I've got some long, fearsome forceps that I'll put in the wound. And I'll be able to fold this out. So again, cyclodialysis spatula underneath, forceps on top, and then I'm kind of using, pushing up with the cyclodialysis spatula, down with the forceps to fold it. And once it's folded, I'm going to have to maneuver the cyclodialysis spatula out, and then I can turn the forceps and remove the IOL. So now the IOL is out. And I decided to use this paracentesis that I'd created because I made it, and I'm going to use it for my irrigation port for my anterior vitrectomy. So kind of do this for a while. We can skip ahead here. Let's see. So did a lot of anterior vitrectomy. And putting in some viscoelastic, and then putting in my IOL. I put in some triesence in the eye beforehand, but putting in my 3-piece IOL in the sulcus. So I always kind of go slowly just so I can carefully make sure that the leading haptic is going in the sulcus, and then kind of pronating my hand so that the IOL goes in kind of as flat as it can. So again, slow is fast. I'm kind of taking my time here really to make sure that nothing else kind of happens that I don't want to happen. I just tuck in the lagging haptic. And let's see, we've got, after that, I end up putting in a cross stitch just to close that 3 millimeter wound that I've created, buried. I think I'll do a little more anterior vitrectomy, and that's the end of the case. Patient did pretty well. After all was said and done, she ended up being 20/25 uncorrected and just had a little bit of refractive error. So she ended up doing quite well, fortunately. So be prepared for anything. I mean, this is the first and only time, knock on wood, that I've had an IOL flip like that, especially after it had been in the eye for several seconds and was starting to unfold in a good way. It wasn't in a very tight scroll. So what I think I should have done in retrospect was not trying to flip the IOL while it was in the bag without adding any viscoelastic. So I think what I should have done was get the IOL kind of up into the anterior chamber, put more viscoelastic above and below, flip it carefully, and then put it back in the bag. And that would have been, I think, the best way to do it. However, I had the result that I had, so I had to keep going and kind of fix my mistakes. So what I did do right was I kept the irrigation going prior to injecting viscoelastic into the posterior capsule kind of opening, because again, if I just panicked, took out my irrigation, then all that vitreous would have come forward, and there would have been more vitreous kind of coming into the anterior chamber. And then, obviously exchanging the IOL for a two-piece lens, and patient did well. So that's my first case of kind of a way that I made this was to be an easy case, kind of a more difficult case. So any questions so far?
Yeah, any comments from the attendees? For sure, just let us know. We can ask the question to Dr. Lin, or if you want, you can just let us know. But Amy, what's really interesting there is that I think the key, but as you have already mentioned, is you didn't yank out that irrigating cannula, right? You put the viscoelastic in, make sure that the eye was pressurized before doing so. I've had a similar situation happen, but one thing that I was wondering about, and curious to see what your thoughts were, is what are the optics of leaving the lens flipped upside down in the bag?
I think there's a little, I think the refractive error, I believe might be a -0.5, but I'm not positive.
Okay. I guess it depends on each lens,
yeah, I've never left an IOL upside down, and I just didn't want to deal with the consequences of that.
Yeah. I ended up leaving one IOL upside down, and it was just like a case where I thought it would be best to do so. And with that particular lens model, it seemed to be okay. So, looking back at it, it was okay. I guess if I had known more about the optics and whether it's, convex surface or biconvex or the toric, all that kind of stuff you would have to know, it'd be interesting. But I think the other thing also is your way of explanting the lens. So do you prefer this way over cutting the lens or Pac-Man?
Yeah, yeah. I mean, I've cut the lens on occasion, and if I cut it, I kind of hold it with an MST forceps. I hold the optic and then kind of cut most of the way through, and kind of and take it and just kind of pull the whole lens out. I've done it that way. I just feel like I just don't want anything sharp, being introduced to cause more damage back behind. So that's why I do it this way. It's a little bit finicky to get used to it, because you have to have the forces just right so that you can still get the cyclodialysis spatula out of the fold. So if you grab it too tightly, you won't be able to disengage that. So it does take some practice, but I found it to be kind of the best for my hands.
And I guess the key is making sure the viscoelastic dispersive is in the eye, so that when you have your forceps through your main wound, that vitreous is not prolapsing through, right? Just
yeah, sure. Correct. Yes.
Okay, yeah. Cool.
Yeah, viscoelastic there. Yeah. Okay, so.
Awesome. Thanks for sharing. That's really interesting.
Yeah. Cool. Yes. Cataract case. So this one actually just happened maybe about 6 weeks ago. Just a preamble. This is a patient who had a PK at least 10 years ago. So it's an old PK, but it's.
Sorry, Amy. Yes. Your volume just went down for some reason. I'm not sure why.
Let me turn off the volume on my. How's that? Is that better? No?
Yeah, it's better. Yes.
Okay. Let me know. So this is a patient who had a PK several years ago, still clear, and I'm just doing cataract surgery through a PK. And again, this has been uncomplicated. This time the IOL is already in the eye, so I'm taking out viscoelastic. So again, final steps here. Hydrate the paracentesis. Sorry, things are upside down, but I see this wave. And I think, is that what I think it is? Did I just put BSS kind of detach, cause a decimase detachment with BSS. So I kind of, not kind of in disbelief, so I do it again, and I make the wave even bigger. Now it's kind of got a big giant Descemet's detachment, kind of underneath stroma. So I'm buying time by hydrating the wound as I think about what I'm going to do next. So again, I've got a big fluid BSS pocket kind of above Descemet's. So I try to get some air in underneath, but it's hard to tell in this video, but I kind of went into the same channel. I've just put air into the that space. So again, now Descemet's really plastered against the IOL. So I get in there, get the air out, so I can put air into the anterior chamber where I wanted it. So I get all the air out. Just have to find the right plane again. Okay, so I make sure I get it all out, and then this time I go in and I make sure I'm literally touching the IOL before I inject some BSS. So I'll get a chamber formed again, touching the IOL. So there's no more detachment right now, but I want to get some air in. So again, kind of touch the IOL, make sure I'm below Descemet's before I've now put a big air bubble in the AC. So I kind of treat it like a kind of the end of a DMEC or the end of a DSEC at this point. So I'm kind of checking pressure. It's still a little bit low for my taste. I want to get a little bit more of an air fill in. So again, I'm making sure I'm in, I'm touching the IOL, get more air in there, and it's a little bit firmer. So I left it like this for a couple minutes. I'm just hydrating the wound a bit. Some of the air comes out, so I'll put some more in. And then I do a little air fluid exchange, oh no, this time I'm putting more air, let it sit for another minute, and then I'll do a final air fluid exchange with a little bit of BSS. So I give kind of a free floating air bubble in the AC, and IOP is good. So this patient ended up doing really well. Post-op day 1, there's no Descemet's detachment. He had a little bit of edema. I put him on some neuro, and by 2-3 weeks later, he was doing really well, no edema. So he ended up doing really well. So even though I had, caused some endothelial damage by, injecting BSS, subsequently air, kind of just above Descemet's membrane, was able to save the case. But again, something very unexpected that just happened just with hydrating the paracentesis. So you just never know what you can expect. Always got to be on your toes, and not, I guess, let up your guard during cataract surgery. That case. So again, I talked about this already, making sure air goes posterior to Descemet's, and then leaving a free-flowing air bubble in the anterior chamber. And I had
your volume just went down again. I'm not sure why. Just 2 seconds ago.
Okay. Let me increase my volume, but I don't know if that changes anything.
I can hear you well now.
Okay. All right. It's just super loud in my ear, so I'm going to take out those. Okay, so I'm going to put this back on the share here. Okay, so I kind of treated it like a post-DSEC case, which is, having the patient lay face up for the rest of the day of surgery, and then all day of the following day. And then after 1 day post-op, then they're allowed to kind of go back to the normal activities. So that was that case. Questions, comments? Anyone had this happen during surgery? Okay, I can't hear anything if anyone's talking. I don't hear anything. Not sure why. Anything here? For some reason I can't hear anything. I'm not hearing anything at all. Assuming, I'm not sure if you guys can hear me. Okay, yeah, I can't hear anything. I mean, I can keep going, but I'm not sure if you guys can even hear me. Should I keep going? Thumbs up to keep going? Yes? No? Because I can't hear anything.
Again, can you hear us?
Okay, now, okay, yes, very loudly now.
You can hear me okay?
Yes, now I can hear.
Okay. All right, sorry. I was just curious, Amy, what do you advise or how do you suggest people when they do their irrigation, or sorry, when they do their paracentesis, trying to make it watertight, they hydrate it, what do you suggest how that should be done?
You know, I think this has happened to me once, only one other time, and the other patient that happened was not a post-PK patient. So what I had been doing for a while was kind of not towards the center of the eye, but kind of making sure I'm kind of always very peripheral. So in case it does happen, you know, I can kind of catch it early. I suppose one could hydrate a little more superficially, and that might kind of prevent this from happening. I don't have a good answer to that, honestly. So it's an N of 2 out of thousands of cataract surgeries.
Yeah. Okay, cool. I think, how would you have managed this differently? Sometimes we get patients with detached descines during cataract surgery while injecting viscoelastic.
Yes.
So how would you have managed that situation?
Yeah, I'm trying to think. I don't think I've had that happen to me, but I really make sure that I am absolutely in the anterior chamber before I inject viscoelastic, because very easy, you could easily start injecting as you're kind of in the middle of your paracentesis, and you're more prone to a detachment that way.
Yeah.
But if you really make sure you're completely in the AC before injecting, then you can prevent that from happening.
Yeah, okay, cool. All right, thanks, that's great.
Right.
Nice case.
Okay, all right. Okay, next case. So this is a different one. So this was a while ago. This is a sex case. The story is this was a young guy who had a history of blunt trauma, had a white cataract on exam, shallow anterior chamber, very intermittent white cataract. His pressure was up. I had him controlled with a couple drops. May have had him on Diamox briefly, but took him to the OR, and I thought, well, you know, there are different ways to address an intermittent white cataract. I was going to try using femtosecond LensX, and I heard people talking about it being really useful for white cataract. So I thought, well, why not? Let's try it for this case. So I know it looks like I put trypan blue in the eye, but I haven't. I haven't done anything. I'm just trying to get a good doc. And you can already tell, I mean, I'll start playing the video, but you can already tell that, you know, I've already docked the patient pretty well. And this is their capsule, and it's it's kind of undulating. So you'll see the reason why in a moment as I play video here. So you see, it's a very, very round lens. So even though I've got a good dock, the capsule is just not very flat. So I'm kind of changing the gates down, but it's a very round lens. You can't even see the posterior part of the cataract. So start the laser, see what happens with the rexes. I was kind of making the rexes, and then what happens, and I couldn't really tell what happened right then, but it actually caused 2 radial tears. So let's slow motion again. So it kind of 2 explosions in the eye. So I think what happened, let me maybe pause here. I think what happened was, you know, when the LensX creates the capsulotomy, it doesn't create an instant capsulotomy that goes through the whole capsule all at once. and it kind of goes around in a circle, kind of goes through layer by layer through the anterior capsule. And so I think there was one portion of the capsule that was full thickness before any other part. So those kind of two portions caused the contents of the lens to kind of literally explode out of the eye. And again, this is a closed chamber, haven't made any incisions in the eye, still had all that pent-up pressure kind of coming out into the anterior chamber. So I got him into the OR and found that his lens was kind of tilted into the anterior chamber. And again, I wasn't sure what was going on at this point. Video quality, I have to apologize, isn't the best, so I'll have to kind of talk through it. So I put some trypan and viscoelastic in the eye, see what's going on. You know, I try to complete the capsulorhexis, so it's not complete as you would want it to be. So I'm trying to complete things, and I think there is a tendency for the rhexis to kind of go out. So I do try the little maneuver, which is kind of going backwards with the forceps to try and bring in the rhexis around. So I kind of see that kind of coming in there. Again, not the greatest quality video, but I am able to complete the rhexis, and I'm able to do the phaco, and again, hard to see, but there are 2 radial tears corresponding to those areas of explosion, which you can't see very well in the video, but the bag is intact otherwise, so no posterior capsule tear. I am able to put a 3-piece IOL in the sulcus for that case. So that was my N of 1 of an intumescent white cataract using femtosecond. I haven't tried it since because of this case. I suppose I could try it again in maybe a lens that I don't think is quite as intumescent, but you know, I've shied away from using femtosecond for white cataracts, and there are, you know, obviously a lot of different ways that one could address a white cataract to prevent the Argentinian flag sign, which didn't really quite happen in this case, thank goodness. But I usually do needle decompression prior to making the capsulorhexis. So what I'll actually do is I'll usually make a paracentesis and then go in with a 25 gauge needle bevel down, right in the middle, and start aspirating as much as I can. And that method seems to work well for most cases. There is the Zepto capsulotomy technique, which I think in theory may be helpful for this case, because that actually makes an instant capsulotomy kind of all at once. It's kind of this nitinol ring that has an electric current running through it, and kind of lay it on the capsule, and that electric current kind of literally zaps a complete capsulotomy within, you know, a split second. So maybe that may have been a better use of technology for this case, but that's not something I had at the time. But I don't know if anyone else has used Zepto for this kind of case, or if there's anything else that you would recommend for like.
I haven't used Zepto. I've been able to use it in like wet lab settings. I've not used it in real life. But how long does the capsulotomy take with the LensX?
It takes a couple seconds. This was an older LensX. I don't know if it's any faster now. I don't usually normally, I've kind of shied away from using femto with cataract surgery now, but it does take a couple of seconds to make the capsulotomy. So that's too long, especially for this, this case.
I see, okay. I don't have experience with LensX, but with Catalyst, it's a fraction of a second to capsulotomy.
Yes, it is faster.
So I've used on a couple of patients. We're relatively new with Catalyst here, but on a couple of patients, it seemed to have gone okay. But it's amazing that you're able to take the lens out without extending that radial tear.
Yeah.
Clearly. So that's really amazing.
Yeah, and I think having actually 2 radial tears may have been a little bit of a godsend, because if there was only one, I think all the energy would have gone into the one, and I think it would have propagated, or would have had a higher chance of propagating around to the posterior capsule. But because there were 2, I think it was almost like a mini can, you know, like the old can opener technique, making lots of little radial tears to relax. I mean, there were two that kind of took the pressure off of a single radial tear. So I think that actually helped.
Okay, cool. And we have, we have an Argentinian that was hoping to see the Argentinian flag, but sorry, not today.
Yeah, no, not on this day, thankfully. Okay, so switching gears, this is a different kind of case. So this is a 61-year-old patient who came to me with Rice-Buchler's dystrophy. Came in for decreased vision, severe irritation in his eyes, and photosensitivity for several years. His mom had corneal transplants in both eyes. And he's been dealing with this for a long time, and he lived about maybe a 3 or 4 hour drive from me. He hadn't seen any eye doctor in years because he was, I think his mom didn't have a good course after her corneal transplants. And so he was just terrified of having anything done. He didn't want to have any sort of transplant, but he just couldn't take it anymore. So he finally came in to see me. So just a little review on Rice-Buchler's. It affects Bowman's layer and the anterior stroma. It is autosomal dominant. There's a mutation in the TGF-beta or big HG gene on chromosome 5. So what happens is at birth, corneas are normal. But then within the first decade of life, patients start having painful recurrent corneal erosions, some subepithelial opacification, and progressive visual decline. So this is not my patient, but these are some close-ups of what it looks like. So you see this reticular subepithelial pattern kind of diffusely, kind of more in the center of both corneas here. And then there's a hyaline-like material which deposits kind of in the anterior stroma and subepithelial area, and it kind of disrupts and often replaces Bowman's layer. So back to the patient. On exam with his glasses, he was 21, 25, 20/70. He's wearing a little bit of a hyperopic correction. We refracted him a little bit better with the 20/50 and 20/30. But he was very, very light sensitive. I could barely examine him at the slit lamp. It was literally like I might spend like a second or two per eye, at a time to really get a look. But there was diffuse Rice-Buchler's in both eyes. Tried to get a picture. Unfortunately, this is the best picture we could do because we tried to get a high mag slit beam. He just would close his eyes. We weren't able to get a good picture, but just on this low mag kind of diffuse illumination, you can kind of see a sense of a little bit of a reticular something happening kind of around the light reflex there. But on exam, it was actually diffuse throughout his cornea in both eyes. So what I decided to do was kind of a version of PTK. So I put PTK in quotes because kind of the traditional PTK is actually with a excimer laser with a single broad beam. You can kind of pulse kind of a large diameter beam all at once to treat the whole cornea all at once at the same time. And that's been described with the Vizix laser. Here at our center, we've got the Alcon Wavelight, which doesn't have the PTK option. So what I did was I decided to use kind of the small flying spot size with the Wavelight and kind of treat -1 and then +1, and I'll describe why. So took off, we usually, with our PRKs, we take off the epithelium with alcohol, so that's what I did. And I'll show a video of all this. Then I did some mechanical debridement as much as I could, and some diamond bird polishing. And I decided to treat -1 and then +1. And the reason why I decided to do this was, I wanted to treat the center part of the cornea, so I needed a myopic treatment, so I went with a -1. But again, he's hyperopic, so if I were to treat -1, I would make him more hyperopic. So I decided to counteract my -1 treatment with a +1 treatment, with the thought that hopefully he would end up being, kind of the similar refractive error. After that, I placed mitomycin and then placed a contact lens. So got a video here. So I did both eyes at the same session. So this is one of the eyes. I sped up the video here. So after I applied the alcohol, I'll start taking off the epithelium, and it's kind of coming off in a irregular fashion. It's not coming off as a nice sheet. There's some areas that come off very easily, and there's other areas that were a little bit more adherent. and kind of take off the epithelium. And you notice kind of in the center, right over his pupil, there's some adherent little islands of abnormal epithelium. So still there, I kind of have to scrape that little island of abnormal epithelium off. So I switched to a grease hopper blade and kind of scrape that off. And then did some debridement to smooth things out throughout the stromal bed. And then I use a diamond burr. You have to be a little bit careful with the diamond burr, especially centrally, and I am using it centrally here, but you have to be careful that it could induce some irregular astigmatism. You can also induce a little bit of haze. Then I treated -1, so you can see the spots out of the center of the cornea. Switched the card, went over to a +1 treatment, and you'll be able to see the spots kind of in the periphery with the +1 treatment there. And then mitomycin, and applied this for 30 seconds, kind of on a sponge, and just making sure I get it all over on the stromal bed. Do a big rinse with some ice cold BSS. And then at the end, put in a bandage contact lens. So did the same in both eyes. So how did he do? So this is my usual post-op regimen for PRK. So antibiotic 4 times a day for a week, topical macular twice a day for 3 days, prednisolone 4 times a day for a week, then twice a day for 3 weeks, and then switching over to FML, TID for a month, BID for a month. So we use this kind of long tapering dose of steroid drops to prevent haze formation. I took out his bandage contact lens after 1 week. So at the 1 month post-op, he was doing really well. He was 20/50, 20/30. Interestingly, he was less hyperopic than he was before. So about a +125 in the right eye, getting to 20/30, pretty close to plano in the left eye, getting 20/25. Still had a little bit of, I guess, residual corneal dystrophy in both eyes, little sub-epi scarring, maybe a little bit of haze in both eyes. By 4 months, he was doing really well. So he was uncorrected 20/30 and 20/20, pretty much +0.5 in refraction in both eyes, correctable to 20/20 now. A little bit of subepithelial scarring. He did have some dryness, some punctate epithelial erosions in both eyes. So I placed some plugs in both eyes. And I don't think I really saw him after that. 2 days after the plugs, he called in, and quote is, "The plugs you put in my eyes have worked beyond my expectations. Dry eyes are barely an issue. Thank you again." I haven't seen him since. This was a few years ago. So, I mean, this was a case where things ended up being a lot better than I thought. A, in getting him to 20/20, which I wasn't really sure I could do. And B, I somehow corrected his hyperopia, even though I didn't really correct his hyperopia. I think what ended up happening is just maybe just with the course of the diamond burr polishing, mechanical debridement, and just the way his eye healed, he happened to, achieve a result of, getting rid of most of his hyperopia. So this was kind of a case that turned out a lot better than I thought. That was it with that case. Questions, comments? For some reason, I can't hear anything.
Can you hear me now?
Yes.
Okay. Do you think that the correction of the hyperopia could have been, because you did the myopic treatment first, and the stroma is kind of there exposed, and then you did the hyperopic treatment afterwards, so perhaps there's more of an effect that was created on the cornea, given that it's been
maybe drying out?
Yeah.
Possibly, but I wouldn't have expected it to be that
effective. Right?
Yeah, that effective, because I got him from like a +2 to +0.5.
Yeah,
so.
Interesting. Well, it's interesting you haven't heard back from him, so I guess.
I'm guessing he's doing okay. He's doing okay.
Did he comment on his photophobia afterwards?
Oh yes, it was a lot better. I mean, after surgery, he was still pretty light sensitive for the first week. By a month, he could really tolerate the slit lamp exam a lot better. So that was a huge difference for him. and he wasn't having any more corneal erosions anymore. So he was really happy.
Nice. Okay. Nice
Yeah.
case.
All right. So I've got one more case. So this is a 41-year-old woman. She had LASIK in both eyes back in 1999. I was not involved in any of her care, and unfortunately, I had no records. But she said she had a LASIK enhancement in both eyes in 2011. So 12 years later, someone did a LASIK, a flap relift, and treated whatever refractive error she had then. And then she, unsurprisingly, developed subsequent epithelial ingrowth in both eyes. And then she had subsequently 2 more flap lifts to try and remove the epithelial ingrowth. Again, no records. She said the second time they lifted the flap, they used some sort of glue. So maybe to seal, maybe resure. And again, I'm not sure what they used, but didn't sound like they did any sutures or anything. She's complaining that her right eye is very blurry, very dry, very painful. She is 20/40 in 2020 with correction, and that's what she's wearing. So she's a bit myopic in the right eye, and we couldn't get her any better with refraction. So this is what her right eye looked like. The left eye had a much milder version of epithelial ingrowth. I don't have a picture of that eye, but this is what the right eye looked like, which was more severe. So we got 4 nests of epithelial ingrowth here. So at the time, I had been reading about the use of a YAG laser on the areas of epithelial ingrowth, and there's been reports that it could be helpful in arresting the progress. So I decided to try it. So I used very low power, about 0.8 microjoules each, and put a ton of spots in. So I was thinking, let's see how this works. And I achieved nothing but making it worse. So I tried to make it better. I actually made it worse. So you can kind of see pre-YAG, post-YAG. This is a few weeks after the fact. Kind of all these little individual islands of epithelium had coalesced into larger areas. So really, I mean, you think all these spots here, especially this spot right here, is a lot worse than before. So the YAG treatment did not work for her. So I decided to take her to the OR. And I took her to the OR because I suppose I could have done this in a minor room, but she was just so light sensitive. I wanted to make sure there was some IV sedation on board. So let me play this. This is sped up quite a bit, but I get into the flap, and it's not too hard. There are a couple sticky areas. Got to work at it a little bit in a few areas, but I am able to get the flap loosened up so I can lift it. And first I just took a dry wick just to kind of push everything back. And then I got more aggressive with the grease hopper blade to very aggressively scrape away all the epithelium in the bed. And I'll actually do it also on the underside of the flap as well. It's not really apparent on this video, but this patient was complaining the whole time. She was feeling pain somehow with all the topical anesthetic and IV sedation. So it was really hard to achieve all this. So I'm showing you the good parts of the surgery when she's not like moving around. But I actually wanted to scrape more, but she really couldn't tolerate her eyes moving around. So I'm scraping as best I can. I do a big rinse, lots of rinsing. Dry everything into position. Flap looks pretty good. I cut a little tag of epithelium off that was loose, and then I proceed to put in sutures. So I end up putting actually 7 sutures down. So it's kind of like, almost like doing a PK, half a PK almost. Bury the sutures, and then just for, just to add belt and suspenders approach, added some resure and then a bandage contact lens. So she was really, really light sensitive. So I saw her post-op day 1. She had the bandage contact lens on. I saw her again post-op day 6. And I decided to remove all her sutures because she was super, super light sensitive, even despite bandage contact lens and everything looking good. So I was thinking, well, maybe she's just very very sensitive, and I decided to take out all her sutures. I ideally wanted to leave them in for at least a few weeks, but I took out all her sutures at just day 6. Post-op week 3, she is 20/30 uncorrected. There's maybe a little bit of epithelium starting to go back here. a few weeks after that, post-op month 2 vision, 2040. She does get to 2020 with a little bit of a hyperopic friction. A little bit of more epithelium here, but it's not really connecting with the outer edge, which is a good sign. So there must have been some nest of epithelial cells somehow that was kind of left there and has proliferated a little bit. Saw her again at post-op month 7, so maybe a little bit more. We can kind of do a little comparison here. So this is post-op month 2. There's post-op month 7, a little bit more, but it's been 5 months in the interim. Her vision's stable. I did see her again at the 1-year mark, and she looked pretty much the same as at post-op month 7. So I've been leaving her alone. I really don't want to relift her flap again. And her vision's stable. She's happy enough with her eye that she doesn't want anything else done. But wondering if you had any suggestions. I've heard of suggestions of using alcohol to treat the epithelial ingrowth. That's not something I have done. But wondering if you have any other suggestions for the ingrowth.
Yeah, these are that's a tough case because I guess it's been lifted a few times before you got to you, right? So it's always hard to know what's happened exactly. I have used alcohol, 20%, and so that, I guess in your situation, it was really tough to get this patient to cooperate to fully do the treatment. But as you mentioned, doing the underside of the LASIK flap, and then alcohol on that, and then on the stromal area, alcohol on that. And we don't have Reshore here, but I have used fibrin glue on the edges, and then all the way around the LASIK flap. And I've not used the YAG laser. Is that perhaps more used when there's growth that you're seeing, or is it more when it's kind of stable? I'm not sure. I got no experience with the YAG laser. I know Elio reported it several years ago. And I think these cases, I just tell the patient, as you probably did as well, just like, we'll see what happens and no guarantees. But sometimes it's tricky with these little areas, that nests that kind of just get in there somehow.
Yeah, so this is the only patient that I've tried the YAG on. And again, I'm very hesitant to try new things. In this case, kind of made me not want to try the YAG again. So I don't know in what cases it is more successful. Like, is it more successful when they're milder and progressive versus stable? I'm not sure. So it just didn't really work in this situation. When you're using the alcohol, how long do you have the alcohol on there?
So I'm usually having it in like a little small bowl, and I'm using my wet cell or my sterile sponge to dip it in and get it really wet, and then I kind of just go to town on the stromal bed as well as the undersurface of it. And sometimes
so you use it to like debride.
Yeah, and just make sure it's there. We have a question. Do you think mitomycin application could have made a difference in the outcome of the epithelial ingrowth?
Yeah, so I had read some articles about mitomycin. I was just a little hesitant in using mitomycin kind of within a LASIK flap. I wasn't sure, so I decided not to, but I think I could have tried it. It may have helped kill off all the epithelial cells in there, but I was just a little hesitant. I didn't want to be having, ending up with any sort of necrosis later on, or, who knows, with mitomycin.
Yeah, because one of the things we always monitor in these patients, as you know, is the flap thickness, and see if there's any thinning that's going on in the areas that are being affected by the growth or whatever is that's there. But was there do you think this was a leftover thing, or was it a new growth of cells going in?
This right now, I think this was leftover, because there's no connection with the flap edge. It's all kind of paracentral. So I think there must have been like a couple, literally maybe a couple, maybe 5 epithelial cells kind of left paracentrally, even despite all the rinsing and the scraping. So I think they were just left there, and those have proliferated. So I think these are left in growth.
The other thing that I've found useful in cases that have been referred or of these is getting an anterior segment OCT and then kind of seeing how it is pre and post-op. And sometimes there's planes that may be a little bit different as well. So in one case I thought it was a single plane, but it actually was not. And so the leftover cells were actually in a different plane than what I thought, like where I was actually working. So I'm not sure how that happened or what that was, but that was kind of interesting.
Wait, so it was like within the flap, not under it?
So it wasn't in the flap interface. It was kind of like a little bit of it was in the stroma, a little bit deeper, but not the interface itself.
Oh, it's interesting.
So
yeah, I haven't done an anterior segment OCT on her. Yeah.
So that's good. So that's been a nice collection of cases, Amy. So thank you so much.
Yes. Yeah. No, thank you.
I think what your if there's any comments from the group, they can for sure ask. I think I was telling our resident who's on the service that you're a great educator, and this kind of shows that because you're showing these cases where things kind of were different and what the outcomes were and what you did. And what's nice is to see these videos in real time and very, very little editing, obviously, to kind of show what the thinking process is, because when you're in the hot seat, things sometimes look a little different. So thanks for sharing your ideas. And I think that the overall issue is sometimes you just got to kind of just think about what's going on, as you did in the first case where, the flip, we're trying to flipping the bag and seeing what's going on and being careful to, make sure the viscoelastic is in before you take out the irrigation. And then also in cases where there is no real kind of gold standard treatment, trying out these ways and having proper follow-up. So thanks for sharing that. I think, did you have any other overall comments about your approach to when these things kind of are really cases that you don't see often, or are cases that you do often, but you find that there's a little bit of a misadventure that comes along your way?
Yeah.
What are your pearls for, especially some of our trainees, to kind of keep your cool head and kind of do it the way the textbooks do it?
Yeah, so I mean, these cases kind of show that unusual things can happen. I mean, especially with the cataract surgery. So, given like all the training that you get in residency and then fellowship, I mean, you have all the skills that you need to kind of get yourself out of these predicaments. And so I think just kind of thinking back to like, okay, how am I going to fix this problem? Just kind of be slow, don't rush into anything. Keeping really helps rather than panic. You can panic in your head, I guess, but just kind of taking a step back and saying, okay, what's my next step? What do I need to do to achieve my goals? Like with the flipped IOL case, it's like, okay, well, first I got to flip it over. Okay, that didn't work. Now I got to take out the IOL. So kind of a step-by-step approach, and just knowing that in the end, you'll get to your end goal.
Yeah. I remember one of my attendings during residency saying, if you break a bag, you still get a great outcome. Just got to do the proper steps to get there.
Right.
So what do you, how do you manage the tricky part of talking to the patient afterwards, or even pre-op cases that are kind of weird?
Yeah, so I mean, so I never really, you kind of like get into a trap where you want to mention every single possible complication that can happen. Not obviously something that's practical, and you don't want to see your patients, with cataract surgery. So sometimes before surgery, sometimes your eye may take longer to heal, depending what happens during the surgery. Then after a surgery, I tell them, look, there was something that unexpectedly happened during your surgery. I couldn't put the lens implant that I wanted to in. We had to do more cleanup. We put a different lens implant. Your vision's going to be really, really blurry for the next, couple weeks at least. It's going to be a longer healing time. You may have some more discomfort, but I'll be seeing you, throughout your. So the key is to really explain what happened. You don't have to say, I did something really bad in your eye. You don't have to say it in those terms, but just that I didn't expect happen. And, you want to make yourself available to the patient and say, look, I'm going to be seeing you, often, I want you to come better, and we'll get you through this process.
Okay, great. Well, I think that's closing in about an hour here at our hour mark. I'm just going to send out this link so that you can download, people attending can download the certificate of attendance and get the credits for this. Thank you again, Amy, so much for your time.
Thank you. Yes.
We'll have it up on our YouTube channel probably by tomorrow sometime. But thanks again so much. It's nice seeing you. Hope to see you in person soon.
Yes, I know. One day we'll be at a meeting together.
All right. Take care.
All right. Okay. Bye.
Bye. Thanks again.